So today's objectives, basic approach to chest radiograph. I'll describe my approach, how I interpret a chest radiograph, the most commonly performed exam in the world from an imaging perspective. We'll learn how to identify and interpret specific signs on chest radiographs and computerized tomographic examinations, an approach to imaging of acute chest pain with must-see cases that we must be able to see and interpret, critical findings that we cannot miss in the acute setting. Now, we'll go through these different types of imaging modalities: the chest radiograph, the echocardiogram, nuclear medicine, coronary angiography, magnetic resonance imaging, and of course, the multi-detector computerized tomography. Now, the chest radiograph is the most commonly performed cardiac imaging test. And the reason for that is rapid, it is cost-effective, it is a safe screening procedure, it is also portable. It can detect cardiac chamber abnormalities, evaluates physiology, instant state of cardiac physiology, 2D representation, unfortunately, but it is very useful in the emergency ICU, CCU setting, and easily provides daily follow-up in evaluating cardiovascular disease. Now, this is a radiograph performed in the CCU after a particular therapeutic intervention. This is an individual with a complete opacification of his right and left lungs, and he's been intubated with an ET tube in an appropriate position above the level of the carina, but also has a Swan-Ganz catheter, and centrally the catheter is placed within the central pulmonary artery in an appropriate position. So after a procedure is performed, quick representation of one, making sure from a safety perspective that the type of procedure that's been performed is the tube is sitting in an appropriate position, and also looking at instantaneous representation of the actual physiology that's been represented in this particular setting, being one of acute pulmonary edema. Now, echocardiography, there's two ways to perform echocardiography: transthoracic and transesophageal. Transesophageal echocardiography, of course, being more invasive, carries with it some risks, such as risk of perforation of the esophagus, esophageal stenosis, some cardiac arrhythmias. However, transesophageal echocardiography is always performed after initially performing transthoracic. And the reason why we perform transesophageal echocardiography is better delineation of the anatomical structures. And particularly if we're looking at mitral regurgitation, as we see in this particular example, blue meaning flow away from the transducer, and this indicates mitral tricuspid regurgitation in this particular example. And particularly if we want to look at vegetations, in this particular example, we can see anterior and posterior. We can see a big right atrium. This is right and left. This is the right ventricle, left ventricle, right atrium, left atrium, and we see these echogenic bright foci at the level of the tricuspid valve, indicating vegetations, in this particular setting, infective endocarditis. Great test, great modality to be able to visualize this type of abnormality. Transesophageal giving us better delineation of the anatomical structures. Now, in summary, for cardiography, transthoracic is the initial procedure to study cardiac morphology, gives us both anatomical and functional information, assessing the size, thickness, and motion of the chambers, stenosis or regurgitation of flow across valves, and also assesses ejection fraction and cardiac output. Esophageal echocardiography, as I mentioned, we utilize this needing better resolution of cardiac structures where the appropriate window is not provided when performing a transthoracic esophageal echocardiogram, particularly for valve vegetations, thoracic aortic dissections, cardiac masses, left atrial thrombi. Then that's when the test of choice is this transesophageal echocardiography. Now, nuclear cardiology, perfusion imaging, this is physiological imaging, not anatomical imaging, is what I would say. And this assesses myocardial viability and ischemia. It is very useful in stratifying from risk and guiding patient management, post-myocardial infarction, angina, preoperatively for coronary artery bypass graft procedures. 70 specificity for coronary artery disease ranges from 80 to 90%. Now, the way this examination is performed, we administer a radionucleotide tracer material that's injected through an intravenous route. And basically, we obtain two phases, both stress and rest. Basically, on reversible defects, that means ischemic myocardium that is viable, it normalizes on rest images. So there's an abnormality on stress, but normalizes on rest. That is pathognomonic of reversible ischemia, which is viable myocardium. If it is a non-reversible defect, meaning that the defect or the lack of uptake of the radionucleotide tracer material in the myocardium is fixed on both rest and stress, that implies an infarct, that implies scar, that is not viable myocardium. So let's look at a normal MIBI scan. Let's concentrate on the top images, like this donut images. These are stress and rest. You see a nice round configuration, nice bright configuration of this donut with a central hole within the central aspect of the donut. Similar on stress, similar on rest along the anterior, septal, inferior and lateral walls of the left ventricle, indicating a normal perfusion scan. Now, if we look at reversible ischemia, we see a defect along the anterior apical portion of the left ventricle on stress. We can see it's not homogeneous. It's not bright throughout its extent. However, if we look on the rest phase, we can see it's nice and round in its configuration, meaning that it is reversible. A reversible defect implies ischemia. Ischemia implies viable myocardium. That is a very useful thing to know from a risk stratification and also pre-CABG procedure where the CABG should be performed, given that we have viable myocardium. It's a myocardium that could be saved from the therapeutic and surgical procedures that could be entertained for this particular patient. Now, cardiac MDCT, it is high resolution, fast, non-invasive. It is used to detect and quantify coronary calcium from prognostic implications, whether you are at a low or high risk for the development of coronary artery disease, and also your disease risk, and also risk for cardiovascular disease morbidity and mortality. It evaluates myocardium, coronary arteries. It is the best non-invasive test we have presently for the detection of coronary atherosclerotic disease. Also, the other big advantage of cardiac CT is a very high negative predictive value. Basically, a negative cardiac CT basically allows you to safely discharge a patient from the ED setting, and basically, from a risk stratification perspective, allows a patient to have a low disease risk outcome from a cardiovascular disease perspective over the next 2 to 5 years. Also, we can evaluate aortic aneurysms, dissections, pulmonary thrombi, and basically the triple rule-out scan in the acute setting, which I'll show some examples towards the later aspects of the talk. This particular example, this is anterior, where the sternum is, posterior, where the spine is, right and left. This is the aorta. And we can see this bright foci is calcium that is present within the left main and left anterior descending coronary artery disease. We can quantify that. We can stratify that. We can put it according to the patient's age and gender and give us a percentile based on the rest of the population as to the risk that this patient poses based on the quantification of their calcium based on an Agassiz score. And that becomes very useful to stratify patients as low, moderate, or high risk. And also that can help us stratify them and also allow us as to how aggressive we would like to be with a statin utilization, aspirin, also ACE inhibitors to prevent an adverse cardiovascular disease event. Now, in this particular example, on this volumetric image, this is anterior, the left anterior descending coronary artery. We can see it becomes completely occluded, indicating an acute occlusion of the left anterior descending coronary artery. In this particular example, this is an axial image of the thorax. This is anterior, posterior. This is the spine here posteriorly. This is the sternum here anteriorly. This is the right aspect of the thorax. The rib cage is bright. We have the left aspect of the thorax. We can see the ascending aorta, nice round configuration, the pulmonary trunk. And then we see the descending thoracic aorta, and then where we see this black curvilinear focus. That should not be there. it should be the same as the ascending aorta, completely opacified with contrast material that lights up under the exposure with a CAT scan or an X-ray machine. And we can see this curvilinear focus is displacement of the intima, the lining of the aortic vessel wall, and that is pathognomonic of an acute aortic dissection, which we'll talk more further in the later portions of the talk. 23-year-old female. There was a concern regarding acute chest pain. Of course, what we can do with CT, not just black and white imaging, but we can also do multi-energy imaging where we can see the distribution of iodine based on the blood supply within the lung. And this unfortunate young female had a thymoma, a mass within the anteromediastinum, and what needed to be determined, do they have a pulmonary embolism? So we can switch off to color-coded images nowadays with CT. And basically on this one single image, we can see that the bright orange is the iodine that is present in the lung parenchyma that is distributed based on the integrity of the pulmonary vasculature. We can see in the left lung, this is anterior, posterior, right, and left ventricle, right atrium, left atrium, the pulmonary veins. We can see nice homogeneous distribution of the iodine within the left lung. But what we can see is an area of decreased uptake, an area of lack of iodine being distributed within the lung in a peripheral, subpleural distribution. We see the lack of uptake of iodine, and those are pathognomonic features of an acute pulmonary embolism in this particular case. Excellent delineation, color-coded images, giving us physiological in addition to anatomical information, where we can now see the lack of distribution of iodine, indicating the presence of an acute pulmonary embolic disease. 23-year-old female, acute pulmonary embolism. Cardiac MR, one-stop complete exam, multiplanar, excellent contrast between the vessels in the cardiac chambers, expensive, not easily obtained, utilized for problem solving, contraindicated in patients with cardiac pacemakers and defibrillators. It can be done, but you need an expert to be able to stop the defibrillator and then turn the defibrillator on after the examination has been completed. Such as congenital heart disease, aortic pulmonary disease, cardiac masses, pericardial effusions, functional information not useful in assessing coronary artery stenosis. Cardiac motion provides functional information for well motion analysis, stroke volumes, ventricular ejection fractions, valve evaluations, and viability imaging as well. MRI is the gold standard for viability imaging and also for the determination of ejection fractions, both for the right and left ventricles. And this particular example, beautiful demonstration. This is anterior, posterior, right ventricle, left atrium, axial image, coronal image, left ventricle, right ventricle. And we can see this abnormal communication between the left and right ventricle along the intraventricular portion of the septum. And that is a true bona fide communication between the left and right ventricle, indicating a ventricular septal defect. Excellent delineation, the size, the flow, the size of the shunt, which is useful information for a surgeon. So excellent delineation with a cine cardiac MRI examination. In this particular example, on your left is what I would ask you to concentrate on. We have a sagittal oblique image. And what we can see is on your left-hand side, this is the left ventricle in short axis. We can see the myocardium anteriorly along the septum and lateral wall. However, along the inferior wall, it is very attenuated, very thin, and we see a bright focus, a curvilinear bright focus. That is gadolinium, a special type of agent that's been injected that accumulates in the extracellular space of the left ventricular myocardium, indicating the presence of scar tissue, meaning that there is no viable tissue, so this patient will not be a good candidate for a CABG procedure to salvage that portion of the myocardium. Coronary angiography, catheter angiography. This is a small catheter that pass the peripheral vessels into the heart of coronary arteries, and contrast is injected to pacify the lumen of the vessels. and then we can obtain blood samples. We can look at the assessment of the coronary arteries. It can be both a diagnostic and therapeutic assessment of coronary arteries. There is some risk of complications, although rare. So what we can do is we can cannulate the orifice of the coronary arteries and inject contrast material, looking at the left antero-descending coronary artery, the left circumflex, the right coronary artery. And then if we detect a stenosis, in this particular example in the LAD, we can do angioplasty and the deployment of a stent and reestablish flow across that area of the vessel. An excellent test, an excellent both diagnostic, therapeutic, particularly for people with high risk patients for the development of an adverse cardiovascular disease event. Now, let's move on. That was the imaging modalities. Let's move on to the second portion of the talk, basic information that we need to know as we lead to a basic approach, the chest radiograph. We talked about the chest radiograph, inexpensive, rarely obtained, but it is a true representation of a three-dimensional structure. There are 5 radiographic densities that are extremely important to know when you interpret a chest radiograph. 1, let's go from the least attenuated to the most attenuated, meaning air, which is the primary component of the lung, the alveolus, is air. It is very dark. It is primarily the composition of the right and left lungs. Then we have fat, which is present in the supraclavicular fossa or in the axilla. Then we have water and soft tissue structures, which is the primary composition of the mediastinum, the hilum, the cardiac chambers, and the aorta. Then we have bone, which is the component of the spine and the ribs. And then we have metal, which is the marker of the technologist and the initials of the technologist that is done to signify the left side of the patient. Or if you had metallic fragments, of course, they would also be the most significantly attenuated structure, meaning they absorb the most, major significant portion of the X-ray beam that is utilized to expose this particular radiograph. The greater the degree you absorb the X-ray beam, the more bright it would appear on the radiograph. The less you absorb an X-ray beam, the more black or less attenuated you appear on a radiograph. 5 radiographic densities, all based on the differential absorption of the X-ray beam. Very key concept, because this differential absorption or exposure allows this different contrast to appear between soft tissue, air, bone, and metal, and allows us to interpret different pathological entities. So basic anatomy. We look at the trachea centrally. Then we look at the transverse portion of the thoracic aorta. We look at the left hilum, composed of the left pulmonary artery, but also the pulmonary veins and also lymph nodes. Then we look at the left atrial appendage, which should be concave, not convex. Then we look at the left ventricle that is convex. And then we move on to the right side. We look at the superior vena cava and azygos confluence, right at the right aspect of the trachea. Then we'll look at the right hilum, which is composed of the truncus arteriosus, which is the main pulmonary trunk that sends a portion of its artery. Initially, it branches within the mediastinum, the right upper lobe pulmonary artery with the right upper lobe bronchus. Then we have the descending interlobar pulmonary artery. And then we have the right atrium. Remembering, and we'll show a schematic depiction, the right ventricle sits in a very anterior located position that is obscured with the left ventricle because they have the same radiographic density. We have the right hemidiaphragm on the right, we have the left hemidiaphragm on the left, and then we have the costodiaphragmatic recesses that form very sharp acute angles. Now, the lateral radiograph is very important as well. This is anterior, posterior, the sternum, the retrosternal lucent airspace. We have the spine at the back of the thoracic spine. And then we can see the right ventricle abuts the sternum. It only occupies 1/3 of the retrosternal airspace. If it occupies more than 1/3, then that's a sign of right ventricular enlargement. Next important structure, we have the right pulmonary artery anterior to the right pulmonary artery is the ascending aorta. Next important structure is the right upper lobe bronchus. Next important structure is the left main pulmonary artery that curves posteriorly. The next important structure is the left upper lobe bronchus. The next important structure is the posterior margin of the left atrium. Next important structure, posterior margin of the left ventricle. And then this straight line is a reflection of the inferior vena cava. And all those are important landmarks to identify, and also the hemidiaphragms are very extremely important, and the costodiaphragmatic recesses need to form these sharp acute angles. And it's nicely depicted on a schematic depiction: right pulmonary artery, right upper lobe bronchus, left upper lobe bronchus, left pulmonary artery. Now, there's a key principle in radiology that we talked about, the 5 radiographic densities, is the principle of the silhouette sign. If two structures with the same density overlap, then the edge between them should disappear. Structures of different densities should contrast against one another and be visualized as the schematic depiction relays to us here. We can see different contrast between these 3 different colors and different radiographic densities. But on the right-hand side, we can see these 2 areas of the same attenuation, the same color being pink. You cannot perceive the different ends of these structures because they blend with one another because of the same attenuation, and that implies pathology from a radiographic perspective, and we'll talk about that, how we use the silhouette sign. So using the silhouette sign, we'll talk more about this throughout the talk. In this particular example, on this radiograph, we have the right and left sides. We have increased density within the right middle lobe. And how do I know it's the right middle lobe? Because the right heart border is obscured. What borders on the right heart border is the right middle lobe. If the left heart border was obscured, that would be pathology within the lingula, which is a portion of the upper lobe of the left lung, which is a superior and inferior segments. So if the left heart border is obscured, that's pathology in the lingula. If the left hemidiaphragm is obscured, and I cannot see the left hemidiaphragm, that's pathology in the left lower lobe. If the right heart border is obscured, that's pathology in the right middle lobe. If the right hemidiaphragm is obscured, that's pathology within the right lower lobe. That is a silhouette sign. Because in this particular example, we have a pneumonia that has the same radiographic density as the heart or soft tissue density of water density. Given they're of the same density, they both absorb and attenuate the X-ray beam to the same degree. So thus they would appear of the same density to your eye. That's why you cannot perceive those border changes as you would on the left, where we can see the left heart border and the adjacent air-filled lingula of the left lung. So we can perceive the border of the left ventricle. So that is known as the silhouette sign. Now, computer tomography is a great test, sub-millimeter resolution. It is the workhorse of the thorax as it pertains to screening and the diagnosis of pathology. We have 3 planes: an axial plane, right, left, anterior, posterior. We have a coronal plane, right and left, superior and inferior. And then we have a sagittal plane, anterior, posterior, superior, and inferior. And this is very useful, the 3 planes, the axial plane or transverse plane, coronal plane, sagittal plane. We obtain that in every single examination we perform. We can also look at the pulmonary vessels, as you can see in this particular example. Very powerful analysis, looking for pulmonary emboli or clots within the pulmonary lungs, or we look for dissections, tearing of the lining of the aortic wall, implicating an aortic dissection, which is a surgical emergency. Now, let's look at this particular example, the power of the CT over an X-ray. This was, unfortunately, an unfortunate incident, a penetrating trauma from a nail gun. We can see that the nail is overlying the right lower aspect of the right hemithorax. We can see there's some opacity in the right lower lobe, probably indicating pulmonary hemorrhage. Now, where is it located? What is the significance of injury? before they take that out, a surgeon would like to know. So then we can perform CT scans where we can slice layer by layer through the tissue, and we can identify and see the the nail gun, that it's gone right through the costochondral junction anteriorly, and it's penetrating within the lung itself. We know the depth, we know the length of the nail, and we know exactly its location. And then we can look at some more imaging, a sagittal image, anterior, posterior, superior, inferior. We can see it's come from a superior to inferior direction, and it's primarily in the anterior aspect of the right lobe of the right lung. We can see this is the major fissure. This bright stuff that you're seeing is pulmonary hemorrhage, blood within the lung itself. So we know the location, we know the length, we know the trajectory, we know what vital organs have been damaged. So this is very important information for surgeons. They can only be obtained from a CT given the sub-millimeter delineation of anatomical structures. Compared to the chest X-ray, very useful, but it's only a 2D representation of a 3-dimensional structure. Now let's go on to the next portion of the talk. Basically, a basic approach to chest radiograph. Very important to know this. It's the most commonly performed examination in the world from an imaging perspective, as we said, and everybody should have a basic approach to the chest radiograph. Now, this is the suggested order. Now, you can define your own order, how you would like to interpret a chest radiograph, but you must have a systematic approach or you will miss critical elements that are present within a chest radiograph. Suggested order, systematic approach. Look at the technique, look at the written data, look at the chest wall soft tissues, look at the abdomen, look at the diaphragms, the pleura, the heart, mediastinum, hilar, lung parenchyma. Very important, this slide, because it signifies a systematic approach to the radiograph. What most people do, and it's common, it's based on behavioral sciences, is that they see the pathology, they concentrate on the pathology and forget about the remainder of the thorax and other pathology lies within the thorax that would be missed and could have significant impact on patient care and outcomes. So, suggested order: technique, written data, chest wall soft tissues, abdomen, diaphragm, the pleura, heart, mediastinum, hilar, lung parenchyma, and we'll go through each one of those and the importance and significance about looking at the technique, the written data, chest wall soft tissues, the abdomen, the diaphragm, the lining of the lung, the heart, the mediastinum, hilar, and lung parenchyma. So initially, technique. Why is this important? Basically, there's 2 ways we take X-rays. 3 ways is what I would say, but for the purposes here, 2 ways. We have a PA projection, meaning the X-ray beam enters from the back to the front. The cassette is placed against the front of the chest wall. And basically, the heart structures, basically, as you can see, the part of the spine, the heart is closest to the radiographic plate, the spine being further apart from the radiographic plate. The reason why we do that is to minimize magnification of the mediastinum and the cardiac structures, meaning the following: the further a structure is away from the cassette, the more it will be magnified. So we don't want to magnify the heart and the mediastinum. I'll show you why, because that could, some folks could incorrectly interpret that as cardiomegaly or enlargement of the mediastinum, and that has significant implications from a pathological perspective. But then we also have the AP projection. And unfortunately, this is the primary way X-rays are obtained in a hospital setting, in the emergency department, trauma setting, CCU setting, ICU setting, and also patients' X-rays that have been exposed on the floors are done through an AP projection, meaning the cassette sits along your back and the X-ray enters from an AP projection, anterior to posterior. The cardiac structures in the mediastinum further away from the cassette, meaning they'll be magnified by 20 to 25%. Important for you to always understand that when you're looking at a radiograph. So let's look at this. Supine AP chest magnifies the pericardial silhouette, incorrectly signifying cardiomegaly, on a proper PA projection, normal size. Remembering, any radiograph that's obtained in the ICU, CCU, emergency department, on the wards is done with an AP projection. So they all have this 20 to 25% magnification effect of the mediastinum and the cardiac thoracic structures. Now, technical factors are very important. You want to look at rotation. So the spinous processes should be equidistant from the medial ends of the clavicles. It's extremely important. Inspiration, the right hemidiaphragm should project along the midclavicular line and intersect the anterior 6th interspace and the posterior 10th interspace. And I'll show you how to count ribs. Basically, you can count them anteriorly, rib 1, 2, 3, 4, 5, 6, or you can count them posteriorly, rib 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And easier to count posteriorly than rather anteriorly, but you can count both. But very important to also count ribs from an inspiration perspective and also identify rib pathology. And then lastly, exposure. A good amount of X-ray beam has been utilized to expose this radiograph. The lower thoracic disc spaces should be seen through the cardiac silhouette or the cardiac structures, meaning the following. I should be able to see a thoracic vertebral body, and I should also perceive a disc space between the thoracic bodies. That implies a good exposure of the radiograph. Not too much, not too little, because those can have significant implications that we'll talk about. So the importance of inspiration. We see that every single day where I work in the ED department about improper inspired radiographs. Incorrectly, people call pathology. Properly inspired radiograph, not that great of an inspiration on your right-hand side. We can see low lung volumes. We can see increased density within the lower lobes, meaning it's bright. This is what's called incorrectly enlargement of the heart, and incorrectly opacities in the lower lobes signifying the presence of a pneumonia. And that was incorrect. That was just on the basis of an improper inspired radiograph. The way we talk about proper inspiration is count your ribs anteriorly or posteriorly, and at the level that the diaphragm intersects the posterior 10th or anterior right 6th rib indicates a good inspired radiograph. What about exposure? Too much X-ray beam makes your lungs all dark. You can't see the vessels. It's basically a non-diagnostic examination. If you don't use enough X-ray or enough juice, you get too much of a white film. That also can signify pathology that you're dealing with pulmonary edema. Now, chest wall soft tissues. Look at each rib individually. Clavicles for fractures, presence or absence of the breast soft tissues, soft tissue meshes, vertebral bodies. Look at the vertebral bodies. Look at the pedicles. Look at the spinous process. Make sure they're intact. They're not destroyed. Usually a metastatic process would destroy the pedicle and the spinous process. It's very common for metastatic diseases to have a predilection for the posterior elements of the vertebral bodies. In this particular example, we can see we have a right breast shadow, but we have an absent left breast shadow. So this patient has had a mastectomy. An important clue that could lead you to believe this patient might have metastatic disease or you're dealing something due to a breast malignancy. Chest wall, counting ribs. We talked about how we count ribs. We can count them posteriorly because we can see the ribs posteriorly. We count initially the first rib on the left or the right, which is the first anterior rib, and then we can count posteriorly rib 2, rib 3, 4, 5, 6, 7, 8, 9, 10. Easy to count the posterior ribs, but you can also count the anterior ribs, rib 1, rib 2, rib 3, 4, 5, 6. Not as easy, but you can. Chest wall, pectus excavatum deformities. Why are those important? What do I mean by pectus excavatum deformity? Incorrectly has someone called pathology within the right middle lobe of the right lung because they could not perceive the right heart border. The reason you cannot perceive the right heart border is because you have indrawing of the thoracic chest wall, what is known as a pectus excavatum deformity. This is congenital. And The only significance is not to improperly call pathology in the right middle lobe, but also to understand that pectus cavatum deformities carry with them some associations of other congenital lesions, such as associations with Marfan syndrome, they have associations with cardiac dissections, mitral valve prolapse, and also Ehlers-Danlos syndromes. Also remembering Down syndrome, people that do pediatrics, hypersegmented sternums, more than 4 to 5 segments, 11 pairs of ribs, not 12 pairs of ribs, are associations with Down syndromes, and those have complete atrioventricular canals and ASD defects, so they have cardiac congenital heart disease. So it's very important to understand that once you identify a thoracic chest wall abnormality, you might also have a congenital heart disorder. Now, lateral chest radiograph. The lateral film, the vertebral body should get progressively more dark as we move towards the infra aspect of the film. If they get more dense, in this particular example, that signifies pathology. Looking at the abdomen, we always talked about looking below the hemidiaphragms. That's the gastric air bubble. We know it's an upright radiograph, but in this particular example, we can see intraperitoneal air, which is a very significant abnormality indicating a ruptured viscus. Then you look at the diaphragms. Look at the diaphragm meets the chest wall. The costodiaphragmatic recess should be very acute in nature, both lateral and posteriorly. If they're not, then that signifies pathology. Look at the pleura. We have the mediastinal pleura, the cupola of the lung, the apex. We have the costodiaphragmatic and the diaphragmatic pleural surface as well. That's important to look at the pleura. The reason why I say this is if you want to diagnose a pneumothorax that we'll go over, remembering the visceral and the parietal pleurals are attached to each other. You cannot perceive them. Once they become detached, your naked eye, if there's air in the pleural cavity, can detect the visceral pleura that signifies a pneumothorax. Remembering that pleural effusions indicates 75 cc's of fluid if you detect it on a lateral, and 200 cc's on a frontal film if you see blunting of the costodiaphragmatic recess. So in this particular example, blunting of the right costodiaphragmatic recess, a right pleural effusion. Mediastinum, the space between the spine at the back and the sternum at the front and the lungs at the sides. It is divided into anterior, middle, and posterior mediastinum. And why is that important? So a very easy breakdown. We find the trachea, we draw a perpendicular line along the anterior aspect of the trachea and along the posterior margin of the left atrium and left ventricle. Anything anterior is the anterior mediastinum. You go 1/3 posterior to the width of the vertebral bodies, you drop a perpendicular line. Anything in between is the middle mediastinum. Anything posterior to this line is the posterior mediastinum. And certain important structures occur in each of the mediastinal compartments that signifies different types of pathology, particularly one being the thymus gland that sits in the anterior supremediastinum. So if you have an anterior supremediastinal mass, one of the most common masses is a thymoma. In this particular example, we can see that there's a soft tissue density that projects along the left hilum. It is situated right here within the anterior supremediastinum, nicely depicted on the CAT scan, anterior, posterior, right, and left, ascending, descending thoracic aorta, pulmonary artery, and that in the appropriate setting is a thymoma, a mass of the thymus gland. That can lead to myasthenia gravis, disruption of the myotendinous junctions that leads to muscle weakness. Heart size. How do we measure heart size? Now, heart size is easily measured by looking at the cardiothoracic ratio. So basically, how do we determine the cardiothoracic ratio? Maximum transverse diameter of the heart, which is A, from the right heart border, the right atrium, to the left heart border, the left ventricle, divided by the maximum transverse diameter of the rib cage. So you find the rib cage and you go on the inside on the right to the inside on the left. That defines the maximum transverse diameter of the rib cage. You divide those two values, and it is more than, let me go back, sorry. If it is greater than 50% on a PA view, that is by definition cardiomegaly. And if it is more than 0.6 on an AP view, that is also signifying cardiomegaly. So cardiac enlargement is a very important determinant. as you see in this particular example. The cardiac enlargement could be a dilated cardiomyopathy, remembering also that big hearts or cardiomegaly could also be pericardial effusions. This particular example, if we follow down the borders, the trachea, the transverse portion of the thoracic aorta, and as I mentioned before, there should be a concavity here, but here we see a convexity after the left hilum, and that's the left atrial appendage. That should be concave. That signifies this patient has had enlargement of the left atrial appendage. Very pathognomonic feature. The patient has had rheumatic heart disease. Now, the right ventricle is an anterolocated structure. How do we determine if there's enlargement of the right ventricle? As I mentioned before, if it climbs more than 1/3 of the sternal length, then this implies right ventricular enlargement that can be seen with enlargement of the pulmonary arteries, with pulmonary arterial enlargement in people that have emphysema and a right ventricular enlargement. So the right ventricle, anterior located structure that abuts the sternum. So if we look at enlargement of the right ventricle, we want to see it creep up more than 1/3 the length of the sternum. In this particular example, we can see it has creeped up more than 1/3 of the sternum. It's anterior, posterior, superior, inferior. So that is enlargement of the right ventricle. Another example, enlargement of the right ventricle, we have enlarged pulmonary arteries indicating pulmonary arterial hypertension. So if we look at the lateral, big right pulmonary artery, big left pulmonary artery, by knowing our anatomic depiction of the hilar structures. And then we have a big right ventricle that is creeped up more than 1/3 the length of the sternum. So let's move on to the hilar. So the hilar are comprised of lobar bronchi, pulmonary arteries and veins, and lymph nodes. So the blue indicates the pulmonary arteries, right upper lobe pulmonary artery, descending into lower pulmonary artery. On the left side, the hilum, the left main pulmonary artery does not branch. You can see the branching here. So the right pulmonary artery, the main pulmonary artery, branches within the mediastinum into the right upper lobe pulmonary artery and descending into lower pulmonary artery. But the left pulmonary artery does not branch. It moves on top of the left lobar bronchus and then branches to give us the descending left into lower pulmonary artery. And that is why, based on this anatomic configuration, why the left hilum sits higher than the right hilum. It is the branching of the pulmonary arteries. The left main pulmonary artery courses superior to the left lower lobe bronchus before it branches. So in this particular example, we talked about enlarged pulmonary arteries. In this particular example, we see a mass along the left hilum, indicating either lymphadenopathy or a bronchogenic malignancy. Lung parenchyma, coming towards the end, it is primarily composed of alveoli, which is gas, it's air, it doesn't absorb the X-ray beam, so it's basically dark, it's lucent, the right and left lungs, that provides a nice contrast medium with the adjacent rib cage and also the soft tissue water density structures of the mediastinum and the heart itself. So now when we look at pathology, I just want to give you some pearls and pitfalls when you're looking at a chest radiograph. Basically, the basic pattern approach to lung abnormalities is the density, the exposure, the attenuation that I talked about at the beginning of the talk. Is it increased or decreased? If it's increased, it's consolidation, meaning pneumonia, interstitial, could be pulmonary edema, nodular masses, that we talk about bronchogenic malignancies or metastases, or atelectasis or volume loss. Atelectasis, volume loss, nodular masses, metastases, consolidation implying pneumonia, interstitial disease, there could be interstitial fibrosis or interstitial pulmonary edema, and that is of increased density. Decreased density, you're dealing with a pneumothorax or emphysema that we'll talk about in the remainder of the talk. Bear with me, here we go. So in this particular example, pattern of disease, increase or decrease? Increase, that we talked about. It's lobar in distribution. It obscures the right heart border, so it's right in the right middle lobe. It's lobar, it's bright, it's consolidation. So it could either be heart failure if it's water, pneumonia if it's pus, hemorrhage if it's blood, lung cancer if it's cells, and protein alveolar proteinosis. Very simplified approach, giving you a very simplified way in identifying what type of pathology you're dealing with. Again, lobar consolidation bright, in a lobar distribution, patient with an increased white count and a fever, it's a pneumonia. The bronchogram sign, what does that mean? Think of the alveoli as grapes coming off stems of alveolar ducts and respiratory bronchioles. If the alveoli are filled with fluid instead of air, they become more dense in the surrounding bronchioles. The outline of the air-filled bronchioles become more visible now. And this is the principle, the silhouette sign that we talked about. So instead of the alveoli being filled with air, they're filled with water, be it pulmonary edema or pus, be it infection. Now they have an increased density of water density. You have the air bronchioles of air density. You're now starting to perceive this branching pattern of the air bronchioles within a consolidated lung or a dense lung, indicating the air bronchogram sign that indicates the presence of consolidation. If you see the air bronchogram sign, it implies you have consolidation. Again, nice depiction of the left upper lobe and beautifully depicted in the right upper lobe of the CT scan. Anterior, posterior, the sternum, the vertebral bodies posteriorly, consolidation in the right upper lobe. We can actually see the branching pattern of the bronchial tree, indicating the presence of an air bronchogram sign, indicating the presence of consolidation. Now, that was consolidation, indicating the presence of a pneumonia obscuring the underlying lung parenchyma. What about a ground glass opacification, meaning a haze on your window? So opacification, increased density. Unlike consolidation, increased density does not obscure vessels and structure around it. Ground glass opacification, indication of fluid or accumulation of fibrosis. So causes of ground glass opacities. So we can see consolidation obscures. Ground glass opacity, you can see the vessels coursing within the area of the increased density. It's very important. I'll tell you why, because we're living through a pandemic, which the primary mode of abnormality of SARS-CoV-2 or COVID-19 pneumonia is ground glass opacities in a particular distribution. So causes of pulmonary edema, SARS-CoV-2 or COVID-19, pulmonary embolism, PCP, ARDS, hypersensitive pneumonitis, and drug-induced causes. This particular example, we can see there's a ground glass opacity in the right upper lobe. We can see the vessel, so it's not consolidation. So let's look at this example, a case from our institution, SARS-CoV-2 or COVID-19 pneumonia. These are color-coded images indicating in green the areas of ground glass attenuation, the coronal representation. But if you look at this axial image, anterior, posterior, right and left, you can see this ground glass opacification. We can still see the vessels coursing through this ground glass or increased density within the lung parenchyma in a posterior distribution. If you see ground glass opacities, those are pathognomonic features of SARS-CoV-2 COVID-19 pneumonia. And those are the pathognomonic features that were initially seen in December of 2019 when the first cases were announced for the pandemic of SARS-CoV-2 or COVID-19 pneumonia. The next thing I want to say, identify the disease. This is decreased. So why is it important? Normal lung, decrease, very dark. That means there's air now that's present in the pleural cavity, indicating the presence of a pneumothorax. So decreased density, pneumothorax, and what is a pneumothorax? Now, remembering the parietal and visceral pleura are tightly opposed to each other. We cannot see them. They're attached to the side of the thoracic chest wall cavity. But as the schematic depiction reveals, if air leaks into the pleural cavity, there's detachment between the visceral and parietal pleura. So how do we diagnose a pneumothorax? We get to see this line. We get to see the visceral pleura because we have now air outlining the visceral pleura within the lung and outside the lung. So we can perceive the visceral pleura. That is a sign of a pneumothorax. They can be very subtle. I'll show you an obvious one, but you can be very subtle as what I'm depicting right here. Subtle depiction of the visceral pleura indicating the presence of a pneumothorax. Pneumomediastinum, air within the mediastinum. As you can see here, lucencies within the mediastinum, nicely depicted on the CAT scan, anterior, posterior, right and left. These air lucencies, these bubbled lucencies within the mediastinum, indicating pneumomediastinum, which can also be a very important thing to detect on a chest radiograph and a chest CT. You can have emphysema where the lungs are very expanded. You have flattened diaphragms, increased AP diameter of the thorax, increased retrosternal airspace, hypodense areas within the lungs. pruning or attenuation of the pulmonary vasculature, bullae, air-containing spaces, pruning the pulmonary vessels and pruning of retention, all features that you're dealing with emphysema or COPD. So you have very lucent lungs, flattened diaphragms, enlarged pulmonary arteries, pruning of the vessels, then you're dealing with COPD in this particular example. And in this particular example, we have a coronal image of a COPD patient, marked lucent left lung with bullous emphysematous disease, some other bulla within the left lung and right lung in a subpleural distribution. So in summary, approach to diagnosis, identify the pattern, increase or decrease, interstitial lines, present or lucencies, nodules, lung volumes, increase or decrease, is it lobar or diffuse, is it upper lobe or lower lobe, is it central or peripheral, and other associated findings such as lymphadenopathy, pleural effusions, enlarged heart, and pulmonary vasculature. So COVID-19, SARS-CoV-2 pneumonia, was primarily a posterior located disease, both upper and primarily lower lobes with ground glass opacities. The last portion of the talk, I think we have a couple more minutes, we'll go through some essential cases and management of acute chest pain. So if we look at this particular example, increased density again, obscuring the right heart border, we've gone over this case, right middle lobe pneumonia. Anatomy, why is it important to know anatomy? This is the trachea that is slightly deviated towards the right of the midline by the transverse portion of the thoracic aorta that sits on the left of the trachea. What about this example? Why is it important to know anatomy? Because on your right is normal anatomy. On your left, though, we can see that the trachea is displaced towards the left of the midline, not the right of the midline. The transverse portion of the thoracic aorta is not sitting on the left, it's sitting on the right. That is a right-sided aortic arch. That implies this patient could have congenital heart disease. You have to recommend an echocardiogram. The only way you can recommend an echocardiogram is by identifying this abnormality initially on a screening chest radiograph by identifying the normal and abnormal anatomy. What is the position of this patient? Supine. Why do we know it's supine? Because the arrow points downwards. We can see the arrow pointing downwards. That means it's in a supine projection, meaning the mediastinum is widened, the heart is enlarged by 20-25%. Air bronchograms, we see these branching air lucencies within areas of consolidation, within the area of opacity, that implies consolidation. Let's look at this example. 30-year-old male presents with chest pain, shortness of breath, vitals, hypertensive, tachycardia, elevated JVP, decreased breath sounds throughout, and hyperresident on the right. What is the appropriate test and imaging test and the appropriate diagnosis? We can see the shifting of the mediastinal structures towards the left. We can see this is the lung that's collapsed. And we can see on the CT scan that this air is lucent. We can see the visceral pleura that I talked about. So the lungs being compressed, shifting the mediastinal structures towards the left with the clinical findings that I described, elevated JVP, decreased cardiac output, muffled heart sounds. Those are signs of a tension pneumothorax. Axial coronal, collapsed lung, the visceral pleura, and the pleural cavity detaching the visceral from the parietal pleura. This is attached to the thoracic wall. So tension pneumothorax is a clinical diagnosis. The arrow is pointing to the collapse of the lung. A must-see case, a must-identified case in the acute setting. You must identify pneumothoraces. Lucent, dark, visceral pleura, collapsed lung, shifting the mediastinal structures towards the left in the appropriate clinical context, a tension pneumothorax. Production, fever, cough, malaise, septic. We can see that there's increased density, again, obscuration of the right middle lobe. On the lateral, we can see minor fissure, major fissure, density that is present. What exists between the minor and major fissure? The right middle lobe. So this is right middle lobe pathology. Counting ribs, we talked about counting ribs, more apparent on the posterior than anterior, but you can count both anterior, 1, 2, 3, 4, 5, 6. Posteriorly, count the first rib, always identify the first rib. And then you can count posteriorly, rib number 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Counting ribs, important. particularly when you're looking at rib fractures. Let's look at a few last cases before we finish with the last 5 minutes of my talk. 23-year-old involved in MVC, initial management, first line imaging test, second imaging test. First, X-ray. Normal X-ray, abnormal X-ray. What's the abnormality? Striking abnormality, wide mediastinum. In a traumatic setting, if you have a wide mediastinum, more than 8 centimeters, that's a sign of a traumatic aortic dissection, obscuration of the aortic knob. We don't see the transverse portion with thoracic aorta. Abnormal spinous stripes, indicating paravertebral hematomas, blood in the apex of the left lung, nasogastric tube, trachea or endotracheal tube deviation towards the right of the midline because of the mediastinal hematoma. Chest X-ray is the first line imaging. And then after the chest X-ray is done, the next test of choice would be a CT scan. Anterior, posterior, right, and left. Ascending aorta, descending thoracic aorta. We can see there's irregularity to the contour of the aorta. This is known as a pseudoaneurysm. In the trauma world, this is known as traumatic aortic pseudoaneurysm. Gets treated. There's a pseudoaneurysm from a cath angiogram. And this now is treated with a stent graft nowadays. You don't have to do open surgery, and patient is successfully treated. Another diagnosis, 65-year-old male, history of hypertension, acute onset of chest pain, pain tearing to the back, asymmetric blood pressure measurements in the left and right hand, wider mediastinum, the patient's been intubated. In this particular setting, normal, abnormal, X-ray, we have a dissection, different type of dissection though, tearing of the lining of the wall, which is the intima. We can see a false lumen, a true lumen. This is the intima that's been stripped off the true lumen that allows blood to percolate in the false lumen, ascending aorta, descending thoracic aorta. We can see the intima that's been stripped off the lining of the wall of the aorta. Blood accumulates in the false lumen as well. So we have ascending, descending thoracic aorta. We have a type A dissection. And I'll go over the types very quickly. Sagittal reconstruction, the dissection involves the ascending aorta down to the descending thoracic aorta. So 3 different types of dissections according to the Stanford classification, but the Stanford simplified it type A and type B. Basically, if you involve the ascending thoracic aorta, it is a type A dissection. Those require surgical intervention to be repaired. If you have a type B dissection, it meaning that it originates distal to the origin of the left subclavian artery, those could be treated conservatively. Dissections are tearing of the lining of the wall of the aorta, the intima. Once this intima is disrupted and displaced on CT scan, we identified as a low density structure in a iodine-filled contrast column within the ascending or descending thoracic aorta. That implies that we're dealing with a dissection. It is a critical emergency, a must-see case, a must-make diagnosis. 60-year male, 48-hour history of progressive shortness of breath and bilateral leg swelling, now presents to the ER with chest pain. So you can use the ACR appropriateness criteria, open up the category thoracic, open up the symptom dyspnea, X-ray having the highest rating as an initial test. Look at the radiograph. Let's put them side by side. Normal radiograph, abnormal radiograph. What do we see? Big heart, opacities throughout both lungs, but what else do we see? We see these linear lines, which is very important. That's why I emphasize this case. Linear lines in the periphery of the lung. These are known as curly B lines, thickened interlobular septa. If you see these curly B lines in the periphery of the lung that are perpendicular to the costodiaphragmatic pleural surface, these are distended lymphatics from elevated pressures attributed to cardiac failure, indicating the presence of pulmonary edema. It is pathognomonic. Curly B lines indicating thickened interlobular septa, distended lymphatics, usually seen in the presence of interstitial pulmonary edema. Pulmonary edema, big heart, pulmonary vascular distribution, curly B lines, S-space alveolar edema, pleural effusions. Pathognomonic features, curly B lines that can be subtle or they can be very prominent. Look for them. They signify distended lymphatics. At this particular case, we see a big heart, we see pleural effusions, we see ground glass densities, signifying alveolar edema. We see curly B lines in the periphery of the lung, the green arrow, signifying distant lymphatics, pathognomonic features of acute cardiogenic pulmonary edema. There's also another type of pulmonary edema, non-cardiogenic pulmonary edema, or ARDS, and that's usually damage to the alveolar capillary membrane, resulting in leakage of fluid into the lung. Numerous causes: trauma, drugs, inhalation of gases, aspiration, sepsis, and pancreatitis. It's perihilar consolidation, normal heart size, no curly B lines, no effusions. In this particular case, normal heart size, increased opacities in the right and left lung, non-cardiogenic pulmonary edema, ARDS, very common thing to see in the ICU. Now, in the last 2 minutes, cardiac CCTA for acute chest pain. It is the test of choice in the ED if you're looking for acute chest pain. Why? As I mentioned at the beginning, it is a high negative predictive value. Basically, if you come to our ED department today and you get a cardiac CTA and it is negative, it has a negative predictive value of 97 to 99% that you do not have any disease, you can be safely discharged home, and you will not have a cardiovascular disease event over the next 2 to 5 years. Basically, it gives you an insurance policy that over the next 2 to 5 years, you will not have a bad cardiovascular disease outcome. Why is it a great test? At our institution, we use the heart score based on history, ECG, age, risk factors, and troponin. And you have a heart score of 4 to 6. Those are the patients at intermediate risk that we target with cardiac CT. In this particular example, just for, you can see this is a CT scan, anterior, posterior, right and left, and it was assessed for pulmonary embolism, but just for time's sake, I'll just show you the pathology. The right coronary artery is opacified initially and then is completely blocked. So this patient came for a pulmonary embolism, but doesn't have a pulmonary embolism, rather has an acute occlusion of the right coronary artery, has a perfusion defect in the inferior wall of the myocardium, indicating an acute infarct. This is an excellent case that I want to bring to your attention. A 42-year-old female that presents with chest pain, elevated troponin levels, gets a cardiac CT scan, and just for time, I'm just going to move forward. We can see in the LAD, the soft tissue density surrounding the LAD, it is significantly narrowed. It's a very distinct condition here that usually occurs in females under the age of 50, but is 50% of the causes of acute coronary syndrome for females under the age of 50 is due to spontaneous coronary artery dissection, SCAD. If it's a condition you haven't heard, it's a condition you should be familiar with. So if we look at the angiogram, the cath angiogram that was done in this particular case, we can see this narrowing of the LAD right here, critical narrowing. If we look at the post-angioplasty that was done, we can see nice opening of the vessel. You save a patient's life. In a matter of seconds, you saved this patient's life. What about so spontaneous coronary dissection? Be familiar with this condition. Causes of acute coronary syndrome in females under the age of 50. This predisposition, people believe it's due to abnormal connective tissue within the vessel wall that causes a rupture of the vasa varsorum, that causes a dissection of the vessel. Traumatic emergencies, indication for cardiac CT trauma. We have clinical criteria, imaging criteria, high-speed deceleration mechanisms, direct steering wheel impact, thoracic seatbelt sign, blunt chest trauma, elevated troponins, fractured ribs, flailed chest, common sternal fractures, retrosternal hematomas, and a hemopericardium. Gunshot injury. Why is this important? Complete whiteout of the left lung, right? This patient, the surgeon wanted to put them on a bypass machine. Axial image, front, back, right, left. We see a bullet fragment at the edge of the left ventricle. We see a contusion to the left ventricle. Now, should this patient be placed on a bypass machine to save their lives? We did a cardiac CT. The surgeon wanted to know how was the left ventricle? Was it appropriately contracting? And was the bullet fragment within the myocardium or outside the myocardium? If it was in the myocardium, they wanted to go to operate and remove that bullet fragment because then it could cause more damage. If it was outside the myocardium, they were going to leave the patient to be managed conservatively. So let's look. These are functional images. We can see the ventricle is not contracting well, poor contraction, which is a problem. But we can also see the bullet fragment is sitting on the top of the left ventricle. It is not sitting within the myocardium. Let's look at this two-chamber view. The left ventricle is not contracting properly. The bullet fragment is sitting on the top of the left ventricle. So no need to take the patient and put them in a bypass machine. Bad outcome if they were going to be put in a bypass machine. Decreased contractility, very poor ejection fraction. The patient probably would not have come off the bypass machine. Cardiac CT, saving the patient's life, directing appropriate management. The last case I'd show, a snowboarder, snowboarding, comes into the ED when I was on. It's trauma to the chest, left side of chest pain. We do a cardiac CT and concentrate on the circumflex coronary artery. So in a matter of seconds, we're looking at the circumflex coronary artery, and we can see, and I'll show you still images, it is completely occluded. Right coronary arteries are pacified, circumflex is occluded, and oblique longitudinal view shows the circumflex coronary artery to be completely occluded from the traumatic insult of the snowboard to the left side of the chest. The patient would have died if they did not have a cardiac CT in a matter of seconds. Took him to the cath lab. We can see there's abnormality to the circumflex. It's occluded. Left anterior descending coronary artery, circumflex coronary artery. Let's look at the post-angioplasty case. Nice depiction. Good lumen compared to this case here, where you don't have a good lumen. Patient's life saved in a matter of seconds. So with that, I would say thank you for your attention. That's the end of my talk. Hopefully you enjoyed it. Real life, real people, real decisions, not the learning channel on Netflix. You know, making a difference when it matters the most, saving lives in the acute setting. Thank you for your attention.
Incredible. Thank you so much, Dr. Nicolaou. We have around 4 questions that I think we could get through if you've got the time here. Excellent.
Yeah, sounds great.
So we have a question from Shakiba Madai from Afghanistan, and she's asking, what's the gold standard diagnostic imaging tool for lungs of a pregnant woman who has COVID-19?
A pregnant woman who has COVID-19?
Mm-hmm.
The diagnostic test of choice, you know, in that particular patient, and I would say, I'll preface it, but depending on what you want to obtain on the clinical situation. If that pregnant patient has chest pain, and we know that COVID-19 patients have a high incidence of pulmonary thrombotic disease, at that moment in time, the correct test of choice would be a CT scan with contrast to diagnose pulmonary embolism. Even though the patient is pregnant, we have to understand that the CT scan, which is performed, is it is very limited to the thorax. There are special mechanisms in place that don't allow the X-ray beam to emit beyond the area of emittance within the thorax. So there's no risk to the fetus at all from a chest CT. So that's one thing I would say. There is no risk to the fetus at all from a chest CT because it is very highly focused to the thorax. And the contrast material that is injected really has no real effect in not promoting appropriate health of the thyroid gland within the fetus itself. So the test of choice, if you're looking at querying quantification of disease of COVID-19, you want to know the severity of disease. If you wanted to know thoracic complications, such as pneumomediastinum, pneumothorax, or acute pulmonary embolism, then the correct test of choice would be a CT chest with contrast material. If it was only needed or required to discern the presence of a pneumonia, then chest radiograph would be the test of choice in that particular scenario.
Excellent. And on that same line of COVID-19 and now onto ground glass opacity, Malad is asking if you could repeat the way to differentiate between consolidation and ground glass opacity in a CSR.
Sure. So I would say to you, ground glass opacity is a density. It signifies interstitial and alveolar inflammation by strict definition. Basically, it is a haze that is present within the lung, and the way we differentiate ground glass opacity from consolidation, if I see a haze in the lung, an area of increased density, meaning a bright focus, but I can still discern normal lung architecture, meaning I can still discern normal interlobular septi, or I can still discern normal pulmonary vessels and normal pulmonary bronchioles. That signifies ground glass opacity. Basically, it's a haziness on your windscreen, but you can still see through the windscreen. That is ground glass opacity. Consolidation means that there's an increased density and opacity within your lung, but I cannot discern interlobular septi. I cannot discern a pulmonary bronchus. I cannot discern a pulmonary vessel. They're obscured by this consolidation that is present. And that signifies consolidation versus ground glass opacity. The window analogy, if you have complete mud on your window, you cannot see beyond your window, that's consolidation. If you have a hazy film of mist on your window, you can still see through your window, that is ground glass opacity.
That's a great analogy. Moving on to aortic aneurysms. So what type of CT is done in aortic dissections and aortic aneurysms?
Yeah, that's a great question. And usually a type of CT that was done is a CT scan with the injection of contrast material that we talked in our previous abdominal lecture. So contrast material, again, I just re-emphasize, are specialized materials that we inject through the veins. They have iodine as a component, and iodine has special, unique spectral properties that it's like a magic compound that once you inject iodine into your bloodstream and you expose it to an X-ray beam, it lights up. It lights up extremely bright and opacifies, basically depicts and outlines the vascular structures, meaning the aorta in aortic dissection, or outlines the pulmonary trunk for the assessment of pulmonary clots, where we see clots in the pulmonary trunk, or we see displacement of the intima, the lining of the aorta for aortic dissections, or traumatic pseudoaneurysms in the setting of trauma. Now, what types of tests are done? It's a CT scan of the chest with contrast. And usually what is done is what we call a gated CT scan, meaning we put ECG leads on the thorax and we time the examination to the diastolic and systolic phases of the cardiac cycle to look at the different phases for appropriate measurements and sizes of the aorta for aneurysms or to look for aortic dissections. And why do we gate the studies? To limit pulsation artifacts, given the aorta and the heart are beating structures. We want to limit the pulsation artifacts, so we time it to the diastolic phase of the cardiac cycle where there's limited pulsation artifacts that are occurring.
Great. And that was from Arij. Thank you, Arij. The next question is from, and there's two parts from Sharia here, and it's what is the indication for MRI heart rather than echo?
So let's look at some classic examples that's happening every single day in the hospital setting. So you have a patient, a young patient. So let's talk about COVID-19. So I'll give you COVID-19. COVID-19 pneumonia, if you get the vaccine, there is a risk in the selected patient population of getting myocarditis. We have patients, in our hospital that have myocarditis from vaccinations. So what is the perfect test? MRI. Why is it a perfect test for myocarditis? Because MRI is an excellent modality that can, one, be gated to systolic and diastolic phase imaging, but also it is excellent contrast sensitivity with a special type of material that's injected like gadolinium, which is the corollary of iodine for when we inject iodine into the body for a CAT scan to opacify the vessels. So gadolinium can abnormally enhance the myocardium in a subepicardial location. Patchy distribution is what I would say, which is pathognomonic of myocarditis. If we see these patchy areas of increased uptake of gadolinium in a subepicardial location, it is pathognomonic of myocarditis. So that we can look at that, for example. We can also calculate that patient's ejection fraction, which MRI is the gold standard. So if you wanted to know a true depiction of somebody's ejection fraction for the right and left ventricle, the gold standard is an MRI, not an echocardiogram. Echocardiogram is a great test, But if you wanted the gold standard, because you would base certain therapeutic maneuvers and interventions, like a defibrillator in a patient, then you would want to do an MRI, because that is the best accurate way to detect an ejection fraction. So patients pre-defibrillators, they get MR scans, like the unfortunate soccer player in the European Cup that had a sudden collapse. An MRI would have been done in that particular case to look at congenital heart defects. Do they have a VSD, an ASD? Do they have an abnormality, what is known as right ventricular dysplasia, which MRI is the test of choice, looking at thinning of the right ventricular wall. It's replaced by fat that predisposes a patient to abnormal arrhythmias that can kill you. So MRI is the test of choice. Another condition, hypertrophic subaortic stenosis, HOCM, is a type of condition that the athletes have that also can have sudden death. Again, MRI, test of choice to determine that. A screening for those types of conditions. MRI is the test of choice, looking for ejection fractions is the gold standard. Congenital heart disease is the gold standard, again, is MR, and also looking for masses, but also looking for these abnormal conditions such as right ventricular dysplasia or hypertrophic subaortic stenosis. HOCM is the condition that can lead to sudden cardiac death and collapse. MRI is the test of choice, even for myocarditis. It is the test of choice to be able to diagnose that pathology.
Excellent. I think we have a few more questions here just to get through them. So we've got a question from Nadia, and the question is, how can we tell apart an AP CXR from a PA just by looking at the image?
I think it's, by looking at the image, you actually can look at, if you just look at the image, it's the mediastinum, and the heart itself is magnified by 20 to 25% is one thing that I would say. The second thing is you look at the rib cage. And as I said before about the rib cage, on a PA projection, the posterior ribs are magnified. They're larger in size than the anterior ribs. Where on an AP projection, the way it's taken, the anterior ribs are larger than the posterior ribs. That's another way to tell the difference, AP versus PA. Magnification of the mediastinum, the heart size. Look at the size of the ribs, anterior ribs being larger than the posterior ribs, which is reversed on the PA projection. And then look at a sign. If you have an arrow pointing, up or down, every X-ray that is taken with the arrow pointing down, it is a supine X-ray. That is, every supine radiograph in any institution is taken in an AP projection. And the other thing I would say, the other clue is, if it's taken in the CCU, ICU, on a patient ward, has to be taken as a supine radiograph. And it has to be taken in an AP projection.
Perfect. So for our last question here from Sohalia, after angioplasty and opening of the left coronary artery, how much risk is there to reblock? Yeah,
the risk in the early days was high. When this procedure was initially invented in the early days, the risk was high of rupturing the vessel, but also the risk of restenosis was significant. A lot of patients were lost in those early days due to immediate stenosis and blockages. The risk nowadays is not that high because of a number of things. Number two, they have stents that are coated with special Taxol coated stents, is what I would say. Another Taxol, as everyone knows, is a therapeutic agent that's utilized in breast cancer patients. But Taxol has anti-angiogenesis properties. So these stents are coated with a special material that prevents new vessel formation, that prevents instant restenosis, is what I would say. So all stents have a special coating that prevents the formation of new vessels, neovascularity, new growth, new instant restenosis, is one I would say. Two, they do appropriate measurements to make sure that there's appropriate differential pressure gradient at the area of stenosis. You need a significant pressure differential to maintain flow when you open up a vessel. Three, what I would say, we also put patients on specialized types of drugs such as Plavix, which is a specialized type of drug that prevents a platelet and thrombin formation to accumulate on the side of these stents to cause in-stent restenosis or sudden occlusion. So coating the stent and also giving the patient oral medications such as Plavix to prevent in-stent restenosis.
All right, great. Thank you for that response. And I think on that point, we can take this chance to wrap up the webinar. Thank you very much, Dr. Nicolaou, for your incredible talk.
Thank you to everyone.
And thank you everyone for attending. Really appreciate all your engagement with the questions and for attending our webinar. And we hope to see you at the next webinar coming up in September. So stay tuned for emails about that. And we look forward to seeing you there as well.
Thank you, everyone. Thanks, James.
Yes, thanks.
Take care,
Thanks so
everyone.
much.
Bye-bye.
Take care, everyone.